This conference will now be recorded.
Right? I just think that, right? All right. Hi, you guys. Hello, everyone.
Hello.
Today we're going to talk about personality disorders part 2. Last time we talked about borderline personality disorder. Today we're going to talk about antisocial personality disorder. So we talked about borderline personality disorder. We talked about cluster B in the diagnosis. There's cluster A, B, and C. And in a cluster are personality disorders with similar features and that are more likely to be grouped together in a diagnosis. Okay, and that's how they separate them. So antisocial personality disorder is in the same cluster as borderline personality disorder. It's considered cluster B. And it's because of the unreliability of behaviors. It's because of the instability in relationships. It's because this behavior, it deviates markedly from the social norm. Okay, just like borderline personality disorder does. And that's part of what makes it so difficult to deal with. So antisocial personality disorder, you're going to find, is extremely inflexible, extremely, to a large degree, not flexible. In order to get diagnosed with antisocial personality disorder, there has to be a diagnosis of conduct disorder before age 15 for that diagnosis to be valid. And this is all according to the DSM-5 now. So we're going right from the current research and the current diagnostic manual. So for a diagnosis of antisocial personality disorder, then the person has to be at least 18 years of age. It cannot be given to a juvenile or a child or a teen. Okay, that would be conduct disorder. So with the person who is diagnosed with this, many people think that it does not lead to stress for them because this is how they are. But just like borderline personality disorder, it is extremely stressful to them, and it leads to further impairment because the behaviors compound. So if I do something that's not effective and then I do something that's not effective, it's not 2 plus 2 or 3 plus 3 is 6. It's more like 3 times 3 is 9, if that makes sense. Because they complicate each other then. So it's like you have 3 instead of 2. So it does lead to distress in the person. And often it's distress related to feedback from others, consequences for behavior, ineffective relationships or unstable relationships, and lack of predictability unless they are in control of the situation. So often there's a history of abuse or neglect, not always. Unstable parenting or erratic parenting is a feature that's commonly seen all the way back to prior to age 15 with conduct disorder. Inconsistent discipline is also a feature that is quite common. And these factors first show up again prior to age 15 with the conduct disorder. Okay, as somebody approaches the age of 18, inconsistent discipline, erratic parenting, if it starts at that point, it really doesn't have the impact. So looking at the cluster B and the antisocial personality disorder, one thing to remember is that culture counts. Okay, for cultural assessments based on parts of the country or parts of the world, it's going to make a difference. In the Middle East, consequences behavior are often corporal punishment. Okay, in the United States, if the behavior or the consequence is corporal in nature, it's going to be more associated with a dysfunction. Okay. So Antisocial personality disorder, however, is not restricted just to the United States. Anywhere that it is markedly different from the culture, it counts. It just might be called something else. So during any initial assessment, that's going to include any kind of diagnostics or impressions, and there aren't a lot of diagnostics outside of the psychiatrist's office or things like that, but we have a lot of impressions that we make based on our experience, based on how the person presents themselves. A cultural assessment is imperative with any initial assessment, okay, to get an accurate diagnosis or impression. And I can't stress that enough. So antisocial personality disorder, it's often a misused label. It's often misused in the fact that if somebody doesn't follow the rules, or if they're rude, or if they're obstinate, very commonly people will associate antisocial. The other thing is that there is a difference between antisocial and asocial. When someone secludes themselves, very commonly the word that people use is antisocial, okay, rather than asocial. Asocial is removal or separation from social experience. Antisocial is behaviors which are in contradiction to effective social interaction and experience. So pay attention to what word you use, because it's extremely common that antisocial and asocial be used incorrectly, okay? So in a person's history, often back to the time of conduct disorder, there's going to be repeated arrests, illegal activity, which shows up in consequences like arrest. And it might start as what's considered fairly minor things, underage drinking tickets or vehicle offenses or fights at school where you're ticketed or suspended, truancy, things like this that are maladaptive. So because it's distressful to the child prior to age 14, the distress will build, okay? There's a factor of the person feeling like they're fixed, like they cannot change. I've always been this way. That's an extremely common statement in kids. This is who I am, deal with it. And that really supports what we consider obstinate behavior. When somebody says to us, well, that's who I am, take it or leave it. And that can put us on the defensive as well. We talked about the separation in authority, that there's always that gradient where, whether it's a case manager or a doctor or a parent, there's always going to be that separation. You're never going to be on equal footing because of what you do. So I'm gonna venture to guess that if a kid would say, well, I've always been this way, deal with it, what are you going to do? That's going to put that person on the defensive, whether it's the case manager or the doctor, or it's going to create a power struggle. Well, you don't always have to be that way. If this is my reality as a child, I don't have the reference for other things or other behaviors. So it's going to create also consistency in the reaction that others have toward the child or the adult. Okay. If I'm breaking the law, somebody's going to think that's not good. And somebody's going to talk to somebody, and then it's not good. So now I got two people that have this assumption about me. They may never say it, but it builds again and it compounds. And pretty soon my environment is either judgmental, isolative, or I'm going to take control of what my environment looks like. So Primarily males are diagnosed with antisocial personality disorder. It has occurred that females have been diagnosed with this, but it is not common. And it's less common as we go through the years. Because criminal behavior with a female, there are assumptions made why that happens. There are assumptions made about sexual abuse, much more commonly made where a female is concerned than a male is concerned. Is there a domestic situation? Much more common to assume that with a female than a male, culturally. So we're going back to the culture, okay? So with interpersonal relationships, whether it's a female or a male, but I'm going to talk primarily from the male point of view, the relationships show consistent instability, ongoing instability. What the instability looks like can change, but the instability is going to be a pattern. It's not predictable. It's inconsistent, okay? And the presentation changes. Of the person and sometimes of the people who are reacting to that person. So the other feature with males who are diagnosed with this, and where it starts with conduct disorder, is very often they have many non-monogamous relationships. There can be sexual acting out or quite a few children. And diagnostically, the research from the DSM through the DSM-4, 3M, 4, 5, that's been fairly consistent in the research. And long-term relationships are not commonly maintained. Long-term relationships, not only with girlfriends and boyfriends, but with friends. If a person has a longer-term relationship with someone, very likely they're going to be on the level of an associate rather than a friend. Because for a friend, there has to be a level of trust. In antisocial personality disorder, as in borderline personality disorder, trust is an issue. So there's instability in self-image. The person may vary their self-image based on the situation they're in. Someone is going to present differently if they're in prison than if they're in the community, and I'll use like the conditional release program as an example. There's going to be some difference in presentation. There will also be similarities which create dysfunction in the outpatient environment that are pretty blatant. And anybody who has been a case manager, a nurse, has worked with this and possibly not recognized it as that, but it's a consistent feature to pay attention to. Very often there is an identification with a specific group. Gang activity is famous for antisocial personality disorder or conduct disorder, because if you appear or behave the same way as me, you can be trusted as an associate, but you're not going to find many people saying that's my friend. Because when push comes to shove, you could turn on me at any time. And trust is again an issue. So pre-age 15 with conduct disorder, that's very commonly when males get involved in gang activity. They're recruited, and it's a very impressionable time as a teenager. Anyone who has teenagers or young teenagers, I'm sure has seen that. So while a teenager is working on developing their identity, it's prime time to get involved in these different kinds of groups. Okay. So just kind of as backing up just a little bit, remember that conduct disorder prior to age 15, it has to be there for antisocial personality, which cannot be diagnosed until 18. So an 18-year-old can present very much like a 15-year-old. Okay. But the diagnosis is going to look different. And one of the biggest difference between conduct disorder at 13, 14, 15 and antisocial personality disorder at 18 further is that the environment that it functions in, that they function in, is going to look different. They may be in a parent's home, in a foster care situation, in a juvenile group home, on a juvenile or teen unit inpatient when the diagnosis is conduct disorder. Come 18, and not always, they may be in the prison system. They may be in a conditional release type program. They may be in a rehab setting like AODA. So keep that in mind, is that the environment will support a change in behavior. And it's normal adjustment to that change. When the environment changes, I need to make changes accordingly. Okay. And within the personality disorder, features are very similar, behaviors often change, if that makes sense. In conduct disorder and antisocial personality disorder, impulsivity, thinking or not thinking before acting, extremely common. Now we're going to go back to borderline personality disorder, where suicidal acts, things like that, extremely impulsive. Don't think before acting. So this is another association why it's called cluster B, why they're in the same ones. You know, the trust, the impulsivity. There's a pattern of repeated lying or deceitfulness. Keep in mind that you lie by telling an untruth, and you lie by not saying anything. So there's lies of omission, and there's lies of commission. But it's both deceit. Okay. Often the person will not recognize it as that. I didn't tell you because I didn't want to X, Y, Z. Extremely valid to the person, extremely valid, but in direct opposition to the environment that they're in, which I'm sure you've seen. So the thinking is often very concrete, all or nothing. Looking at borderline personality disorder, we're going to see the same thing. The all or nothing, love you, hate you. When there's that kind of inconsistency, trust is pretty rarely able to be established because it's unpredictable. In order to trust a person, there has to be some sense of reliability and consistency. And not only do I assume that's not true for you, but it's my life. I'm inconsistent. People react differently to me. So one supports the other. Whether the people outside of me are consistent or not, I'm going to make that assumption. So irresponsible behaviors, often people think criminal behaviors and bigger criminal behaviors, but you're going to see things like inappropriation of finances or lack of responsibility with finances. You know, I get my income, and rather than pay the rent on the 1st, by 10 a.m. on the 1st, when my rent is due at 2, my money's gone because something took my attention. Or I owed somebody money to avoid a consequence. Or I was involved in a relationship where I gave it to someone, a girlfriend, a boyfriend, very common. Okay. Often an assumption is made, if I spend my rent at 10 a.m. on the 1st and it's due at 2, we'll figure it out. There's no realistic chain of events at the time. Very impulsive. Don't worry, I'll figure it out. My landlord will give me till the 5th. I'll figure it out. And then that's where some of the more illegal activity can come in. Beg, borrow, and steal. So that's pretty common. And rent is a good example because almost everybody has some type of financial responsibility for something, whether it be rent or child support or bills or a car payment. Okay, so keep that in mind. The other thing too with finances is that people that carry the diagnosis of antisocial personality disorder, it's through all classes of finances. A lot of money, no money. Okay. If you think about the behaviors that a person gets involved in, drug use and sales, a lot of access to cash. Okay. Someone who comes out of an institution and might go into a conditional release program after 6 years, very little cash. So the behaviors are often consistent, but the tools change. Okay. So it's really going to be pretty specific to the individual. The themes can be common: illegal activity, inconsistency in relationships, but the details are going to look different. So the person is very aware of their behaviors, extremely aware, and they're very hyper alert in the environment. So authority, boundaries, that's where this becomes glaring. If I'm obstinate to authority, I know darn well what the expectations of that authority figure are, and I know darn well that I haven't followed them in the past. Otherwise, there would be no power struggle. Okay. So boundaries with peers, boundaries with case managers. 9 times out of 10, and I've seen this probably probably about 10 times in my entire career where a person gets involved with an inmate or a patient. Boundary testing is huge, huge, because you are not my equal. You are a tool somehow in my agenda. So I've seen women and men get involved with inmates. I've seen women and men get involved with patients in the locked-in patient setting. There have been staff, and I'm thinking of one specific staff who actually quit her job at Winnebago to adopt a 16-year-old boy who was diagnosed with conduct disorder. And that just blew sky high, because the principles are very similar. So barriers, very little awareness of barriers. There's a lot of opportunity in the eyes of somebody with antisocial personality disorder. People, places, and things can be useful as tools to me because there is an agenda, and I'm the agenda. Extreme grandiosity, even if it's not reflected outward, self-serving, okay, rather than someone who has altruism or is very giving. But if there can be gestures of generosity, there can be gestures, but often it's as a tool to get something back. And don't get me wrong, I mean, a person may not function like this 24/7. It's going to present itself at different times. Using teenagers on youth services at Winnebago, they're not always going to present as obstinate. And that's where the trap can open. He's so sweet. She's so sweet. He's so cute. She's so cute. And as a person gets older, it's the same kind of reactions. They're so nice to me. They're just like me. We have so much in common. He does things for me that none of my other boyfriends or my ex-husband did. Makes me feel pretty, makes me feel smart. But I'm a tool in the game. So, and this happens within heterosexual relationships. It happens in same-sex relationships. It happens between someone who is a 19-year-old antisocial and a 15 or 14 or 13-year-old teen with conduct disorder. So don't restrict it to just heterosexual relationships. That's just not the case. So authority, boundaries, rules of any kind. Rules are suggestions. Rules are not concrete. If you give me rules, those are suggestions. And that gives flexibility for me not to follow them. If I question a rule, I'm going to have, most of the time, some kind of argument that may cause someone to go, oh, did we check that? Or is that plural? Or he may or not have a point. And not all the time, and less likely with adults than kids, because the system with children involves so many other people than adults. It involves the child, it involves the parents, it involves the teachers, and communication between all those avenues is extremely difficult. So it's opportunity to play one against the next, or to play two together, or to split. Okay, very common behavior in conduct disorder. Common behavior in antisocial disorder in the sense that I'm going to look to split the authority figures. I'm going to look to split the staff. That power differential we talked about, that's what I'm going for. Because if I can create some inconsistency, it gives me more room to do what I'm going to do. Extremely common, and I saw it just time and again in the inpatient setting where staff were split, and it really, really caused problems.
And I would say sometimes it's not even that we don't want that to happen, but I can remember at more than one staffing with one particular gentleman, we thought we had it spelled out so clear, black, white, yes, no. Damn, within 2 hours, he had nuances thought of that just didn't even occur to us. And there he was, going crazy with it.
Yep. Yeah, it's hard. You have to listen. You have to, structure is very important, but the more concrete I am, it might give that person more room to play around with it. And I think that's what might have been described. So the person will most of the time see their behavior as justified or necessary. And there's a difference between the two. And just an example, and it's not limited just to this one example. If I have the assumption that I'm picked on and I break a rule to yell at a staff, well, you picked on me, so that justifies me blowing up. Okay. On the other hand, if I steal money, property, drugs, food, I can justify that, which is different than feeling like it's justified, as necessary. Nobody else is going to do it for me. It's still that obstinate kind of presentation, but it's the difference between my behavior being okay because it fits the situation, whether you believe it or not, or being necessary for my livelihood. The picture of what my livelihood is, the picture of what my needs are going to be skewed. I think, obviously. So in the last 10 years, the therapy that they have developed and expanded on for antisocial personality disorder is DBT. DBT is very focused on just the skill development, but more importantly, we talked a little bit about the chain analysis with borderline personality disorder. So if I conduct myself in a certain way, we're going to go backwards again. Because if I skip to here, all this is going to be irrelevant. And I'm going to be justified. I'm going from point A to point Z. And my behavior is justified. You're picking on me, so I blew up. Okay, so let's start with blow up. Why did you blow up? Because I couldn't do this, because you said I broke that rule, because I did this, because the rule says, because I was given a copy of the rules, because I said I understood the rules. So it makes a big difference between you're picking on me and so I'm going to blow up at you. What happened to all this? What happened to all this? It's really important in those chain analysis to nail as much as you can backwards, because it takes away the wiggle room. It really takes away a lot of the wiggle room. Not totally, but one of the tools to use is not me telling you, but you telling me. And I'll wait. I'm going to ask you a question. And I'll wait. I got time. And that can be some of the most uncomfortable silence for an antisocial who wants to take control that's ever been. And if at Winnebago, I did a responsible thinking group, responsible behavior group. Everyone in the group had the diagnosis and pretty strong justification for the diagnosis of antisocial personality disorder. And one of the best tools I could use when I asked for input or explanation is, I'll wait. We got 50 minutes. I can sit here for 50 minutes. And people will squirm. Borderline personality disorder will squirm for a different reason than an antisocial personality disorder. It's going to present differently. But keep in mind, it's a beautiful tool, because then I am still driving the bus. I'm not coming down on anybody. I'm not doing anything that could be perceived as condescending. I'm not naming a consequence to a behavior. I'm just saying, I'll wait. Let's see if we can come up with that. I'll wait. And then if the person says, well, what do you think? A great response is, well, it's not about what I think. This is your life. And you kick it back. So that's really, really a helpful tool. The chain analysis needs to come from the person, not from the provider. I'm not going to offer very readily what I see, except for the concrete behaviors, because it's not my place to say, well, it's because of X, Y, Z. I know what the behaviors are. I really, if I think about it, really don't know the motivation, the true motivation. And sometimes that's hard, because as a provider, you want to say, well, I know you did this because of this. You want to say that. Okay. Very rarely do you know. Very rarely do you know. Your reaction is going to be based on assumptions you make based on the behaviors you see and the tools you have, like a page of rules. So, so that power differential, be careful how you use it. You can use it much more effectively by saying, well, we got 50 minutes, I'll wait. Then, if you don't participate, you're going to get kicked out of this group. Very, very different. And it's going to cause a different dynamic to develop. So structure, very concrete structure, can be used by the person to create doubt. Okay. However, predictability can be a very important tool. If I say I'm going to do something and I do it, it's going to develop over time, it's likely to develop, for lack of a better word, almost a respect. I would rather have you respect me than like me. I'm not here to be liked. But in order for me to do my job and to help you and for you to help yourself, there has to be some level of respect. If there's not, that's a different ballgame. Then we have to look at that. The other thing too is consistency. If I do things one way with you and a similar situation happens again, if I have a completely different reaction, I'm completely unreliable. And then C, I couldn't trust you from the beginning. So the consistency is very important. Consistency among different staff is huge, because the lack of predictability over a group of staff, the lack of consistency throughout a group of staff is going to create a problem. And that's where the split can occur. And keep that in mind for borderline personality disorder as well. I mean, we're talking again about these being in the same cluster, the cluster B. And in the beginning, I said there's some of the similar features, but a person that may be more likely to be diagnosed with both. That's why. And it can be incorrect or it can be correct. People at different levels who are diagnosed with borderline personality disorder are more or less likely to be diagnosed with antisocial personality disorder. And a lot of things can play a part in that. Cognitive functioning, prior history, present circumstances. I mean, things can contribute to it. So it's not always going to look the same. If a person is more consistent, more predictable, and fair, perceived as fair, which is going to come from predictability and consistency, there is much more likelihood that the person is going to cooperate. They might cooperate with an angst, but there's much more likelihood of the person cooperating. And I would rather have someone cooperate than like it or like what they are doing. Okay, because that's not what it's about. There's much more likelihood, if there's fairness, consistency, and predictability, to have some type of consideration. But you have to be careful, because if I show you consideration or care, there can be a split. I can use you as a tool. Okay. So to acknowledge maybe a cooperative behavior for what it is and not go beyond that, for example, well, he did X, Y, and Z because I'm his favorite staff. There's a problem. You took it one step further, okay? And that's going to increase the likelihood of all that splitting and somebody getting, for lack of a better word, sucked in. A person who gets involved with someone with this diagnosis, they make choices all along, but when it comes to fruition or it comes to light, they're going to blame each other. They're going to blame each other. So the staff did special favors for me. How was I not supposed to think she liked me or wanted to get involved with me? Okay. The patient or the resident treated me differently than other staff. I was his favorite staff, which is going to increase my vulnerability. And that's going to affect the choices I make. Not everyone in this profession is going to make it through. People get involved or do things for clients that can be illegal, immoral, against the rules, or just in a challenging nature that's not going to fit their role. It's going to happen. It's going to happen. But be very mindful that it doesn't happen to you. But the rule, it takes two to tango. It takes two to tango. Okay? If my personal life is such that I feel more vulnerable, someone with this diagnosis is going to see that. They're going to be able to identify my vulnerabilities, because that's what I do for a livelihood. You are a tool to me. So I have to identify some level of vulnerability for me to be able to use you as a tool. And by vulnerability, I don't necessarily mean the person, the recipient is in an abusive relationship or anything like that. They could have, if it's a woman, she could have 4 children and be stressed to the max. that creates a vulnerability. She may have no history of abuse. She may have a really stable home life, but vulnerability is fed by life circumstances. Okay. I love my 4 children, but oh my God, I'm over the top with stress. So keep that in mind. It's not always, pathology. It's not always because the person was sexually abused as a child. It's not always because they need X, Y, Z, or they're not loved. Or you need to keep that in mind. That vulnerability can present itself all different ways. So for staff and for providers, what's really important, and I'm going to just run down these again: fairness, consistency, predictability, and respect. Okay. There's a level of tit for tat with someone with antisocial personality disorder. If you do that to me, and it's my perception of what you did, I'm going to do twice. Or I'm going to do it at a level where you're going to regret what you did. And I don't necessarily mean with physical assault or abuse, or that happens sometimes, but more likely it's going to be presented with behaviors or things like that. One of the biggest things, and we said this with borderline personality disorder, is be kind. Being kind does not necessarily mean I'm going to give you everything you want. I'm kind to my coworkers. I don't have to like them to be kind to them. I don't have to like them to be respectful. Okay. I don't have to like them to be fair. Okay. Consistency, predictability, fairness, respect. That's about me. That's not about that person. And that's going to help give me a foundation for more effective behavior with this client. So that being said, and I know it's a lot, do you guys have questions or scenarios that fit? Or
just a reminder, if you're thinking about a particular client, don't use a last name.
Right.
In your example.
Mm-hmm. Any questions from anyone?
Would you say that Winnebago really checks out if they really did have a conduct disorder diagnosis as a young person, to attach that label when they are indeed older?
No. I'm going to be very honest about that. No. It's much more likely if the child has been in the Winnebago or Mendota system.
Okay.
Okay. Because the time, and I understand this to some degree, the limited time that any of the disciplines have for assessment often don't allow for it. That doesn't make it right. Okay. But if I have to have my assessment as a social worker done and in the chart in 72 hours, how much information am I going to miss? The psychiatrist has to have their initial assessment done and in the chart in 24 hours. How much information am I going to miss? If that person has been on youth services 2 and 3 and 4 times, I'm going to cite that record because it makes my job easier and it's available, pretty readily available. So going back to the answer, no, I can very clearly say no.
When we go in and do assessments, let's just say for Berry House, for example, there's such a cluster of diagnoses that are in that chart. And then usually someplace along the line, antisocial is stuck in there. And of course, that brings up a big red flag because I think, well, okay, I'm going to take them out of this setting and put them in another setting. And is that really, should I even take them or not? Because once you have that antisocial there, you get all these acting out things like you just described. So it's hard.
It is very hard. And sometimes looking at the history, if you have time, the developmental history, the substance use history, going back to when the person was young, those can be telling.
We have as much time as Winnebago does.
Yeah, so it's hard. But at any time, keep in mind that At any time, keep in mind, the record can be changed. It happens all the time.
Yeah.
So constantly use it as a tool, not as a law. That's the best advice or the best suggestion I can give, is the record is a tool. It is not the law. And it really can help to point you in the right direction. But again, be careful not to make those assumptions. Even a psychiatrist shouldn't make that assumption. But to make the job easier, if someone is diagnosed with bipolar disorder and they come in my office and they've got the mood instability and they're on Depakote, very likely I'm going to diagnose them with bipolar disorder. But then if they get a little iffy on their meds, all of a sudden they're hallucinating or they're delusional. That's really components of schizoaffective disorder, which is a whole different animal. Whole different animal. Someone with schizophrenia is much less likely to have a diagnosis of antisocial personality disorder. Someone with bipolar disorder, because of the marked impulsivity, is much more likely to have a diagnosis of antisocial personality disorder. So the diagnostics in the chart is a tool. Use it as a tool and not as law. And consistently look at the presentation. And because being up close, you're going to be a really good gauge. So then you've got different issues, like, is the psychiatrist going to listen to me? Is, whatever. But that's a whole different quality.
I have a certain client that I don't think is diagnosed with the bipolar or the antisocial, and she fits almost every criteria in both Warren.
Borderline.
But not diagnosed with it.
Really?
Yep.
One thing that can be a tool to a psychiatrist is to talk about features rather than the diagnosis of. If I talk to a psychiatrist about, I see these features, which really look like, borderline features, that can make a difference rather than say, she meets criteria for borderline personality disorder. Who are you? That's a reality. Who are you? So, and it's an unfortunate reality, but if I'm going to identify features and much more readily than I'm going to cite a diagnosis to a psychiatrist or a primary care or a therapist or probation agents, be careful, because antisocial personality disorder is a huge buzzword in probation and parole. Because you're not here because you followed the rules. Okay, you're here because you have a pattern of breaking the rules to the level where you're coming to see me. So be careful what environment you're in. Talk about behaviors and presentation rather than diagnoses.
I want to go back to something you said originally. You said a lot about, this is about culture.
Mm-hmm.
And if I read the articles correctly, where this often gets diagnosed culturally is our Black people in particular.
That is correct.
Get nailed in school systems as
Yep.
being antisocial, when in reality they're not. It's
Correct.
cultural.
That's right.
And the label gets attached, and we know the consequences to that.
Yep. Profiling is a very real thing. Not just sometimes legally, but psychiatrically. There is a level of profiling. A woman who presents identical to a male, the female is much more likely to be diagnosed with borderline personality disorder, and the male is much more likely to be diagnosed with antisocial personality disorder, even though some of the characteristics are, because some of the characteristics are the same. Even so. So, at the risk of using the word profiling, because I know that's a big word, I don't know what other word to use than that. Assumptions, cultural, assumptions, things like that. So, other questions?
I think you gave us good tools with that chain analysis. I think that's something everybody can do, and especially if you're looking for the client response instead of us feeding that information.
And that's hard to do as a case manager or provider, not to feed that information. So that's where some of that, I'll wait, comes in. And it's going to be uncomfortable for you too.
And when you do that as well, it helps them understand why they're doing what they're doing as well. When you go through that change.
It can. Even more glaringly, it helps them understand what they did, the reactions to things. The why comes later, because in order to have why, you need to have insight. In order to identify behaviors, all I need to have is clear observation of patterns. But it can be both. Insight takes longer. So, and that's more connected to the why. So, but both are very possible. That's why DBT has been adjusted and utilized. The other thing too to remember is that DBT for antisocial and for AODA is not meant to be years long. It's considered a shorter term therapy. And by shorter term, I mean a year or less. Some people, in some therapies, it's 6 weeks or 12 sessions or whatever the case may be. Usually it's a year or so, and not really much more than that. So, other questions, comments, concerns?
Did you actually see progress over time with all your antisocials in one class?
Some, not all. Some, not all. I saw more progress with older patients than with younger, because there's still room for someone who's developing. So I saw more improvement with older patients and clients. Yeah. One thing to keep in mind is that with borderline personality disorder and antisocial, and this is not a law, so keep that in mind, people age out of certain behaviors, okay, simply because they age, okay? So it's quite common where you're going to see that, where you're going to see an increased level of cooperation or maybe a little more development of insight to come as someone gets older. And very commonly a statement that a person will make when they're older is, yeah, I'm just tired of being this way. I'm just sick of it. And so it's going to wear on the person. And that goes back to, this is a very real thing that causes a person distress and discomfort. And if that goes on for years and years, yeah, I'm going to be tired somehow, mentally, physically, whatever the case may be. And that happens naturally as we age. So, other questions, thoughts?
How do you get your team to be all on the same page with people like this?
Sometimes you don't. That's just going to be,
Well,
yeah.
but what are
some tools?
suggestions? Yeah.
Some tools are going to be to utilize, and this is a big word, documentation. If it's not in writing, it never happened. And staff performance, and I'm not saying to get anybody fired or anything like that. It's not that level. But the only way to establish the inconsistent approaches is to look at the documentation. If the person has a behavior and staff documents in the chart, this is what happened and this is what the result was from staff, and then all of a sudden 2 weeks later you see the same behavior, different documentation by a different staff, and there's something different as a result, right away the consistency is gone. The predictability is gone, and that's where problems really happen. So one thing to think about is documentation. The other thing to think about is staff training. Staff training for understanding not only what these behaviors look like, but kind of what the common agendas can be. A third thing is going to be compassion for the person and each other. So Involve the person in the process. Okay. Involve the staff in the process. If there is inconsistent behavior with 2 staff, call it. Call it. And let the patient or the client know that you see it. Call it. So, yeah.
I was just gonna say, because I've had issues with this in the residential homes, and I've noticed that debriefing after incidents happen has really helped, just so, you know, bringing all the staff together
Mhm.
and then kind of talking about what happened and what everyone could have done differently. Sometimes people don't think, I mean, all staff thinks differently, and they
Right.
say, oh, well, I
Right.
could have handled it that way, and then it's being able to take the constructive criticism. But I've noticed that debriefing really just helps staff.
Debriefing can help
Yeah.
because
If
it
you see the
puts,
staff person.
Yeah.
and just gathering the staff together gives a sense of unity.
Yeah.
You know, the other thing too, there are some really helpful tools for debriefing that create documentation that can be helpful. If there's any type of physical intervention, whether it's an escort to a room or otherwise, having a mannequin on a piece of paper and who did what, extremely helpful. So the patient doesn't come back and say, you hurt me. She didn't hurt me. She knew how to manage that. She knows her job, you don't. So those kind of things, mannequins, very helpful. Okay. A list of the rules along with the documentation of what happened, extremely helpful to have in the chart. Because if the chart gets this big, the list of rules is probably under the assessment section 200 pages back. And what if they changed? You're still going to have the old copy in there. So that speaks to documentation. Documentation can support success or it can support failure. And it's just a huge, huge common link that needs to be there. So think about the tools that can be used to create that predictability, that fairness, so you can call things. And this is why. It also takes away the I'm telling you. This is the tool. This is what this looks like. You were aware of this. That has nothing to do with me. Okay. So it depersonalizes it. One of the biggest reactions that staff will have to behaviors or reactions of people with antisocial personality disorder is defensiveness, anger, and frustration. And very rarely, if someone calls me whatever name, am I going to feel hurt about it? I'm going to be mad. Okay. And then that power differential gets inappropriately. So keep that in mind, your emotional reactions too. So you have to go home at the end of the day. So how many of those reactions are you going to carry out the door? One thing to keep in mind is that whatever that door looks like, whether it's an institution or it's a vehicle or it's an office or it's a coffee shop or it's a patient's or client's home, leave your stuff at the door when you go in. And emotionally and personally, it is so important to leave their stuff at the door when you leave. Not only does it help support my mental health, my emotional health, I'm going to be better at my job. I'm going to be better at my job. And I'm going to be more effective. I'm also going to have less likelihood of burnout. I'm going to have less likelihood of inappropriate interaction with client or patient. And I'm going to be more consistent overall.
And happier at home if you leave it.
Just at home.
I would suggest that's probably another whole in-service that you could do, because that whole emotional thing is just.
And we can definitely look at that.
Yes,
because
I think we need to.
it is a whole dynamic.
Yes.
So
The line of work, really, it's just something that
Yes,
you have to be able to separate.
Mhm.
it's very hard.
And it is very hard.
Yeah.
It is very hard. But really, if you think about it, in any line of work, no matter what you do, if you work at a restaurant or if you work at a group home, there's that level where you need to leave your stuff at the door
Again,
across the board. But it's going to look different. So, so other questions, comments?
Thank you.
Well, thank you.
Thank
It was
you.
very
Yeah.
interesting.
And next time we are going to talk